Very pleased to participate in this symposium about PlasmaJet, which is a device particularly used since January 2009. So I'd like to present you the postoperative recurrences and fertility rate following endometrial ablation using plasma energy, and to draft the evolution of my practice using PlasmaJet. Well, although the cystectomy is used worldwide by a large majority of surgeons, gynecological surgeons, to use to treat ovarian endometrioma, nobody should overlook that it presents three major disadvantages. First, it significantly decreases the ovarian reserve due to inadvertent excision of underlying ovarian parenchyma, because there is no histological and no surgical cleavage plane. Secondly, the rate of recurrences in women who have given up their pill in order to be pregnant, the rate of recurrences is pretty high, up to 29%. This is results from randomized controlled trials of Recurrence, and is almost the same in another randomized controlled trials of Cystectomy. And third, it significantly decreases the results in IVF. Well, bearing these results in mind, one may think that we should try to do differently, namely not throwing the ovarian tissue along with the cyst wall. And happily we have a solution, a more appropriate solution, in my opinion, to women to offer to women intending to get pregnant. Is not to excise the ovarian cortex along with the endometrial cells, as they are separated by fibrosis, which thickness is about 1 millimeter. So we have 1 millimeter to protect the ovarian tissue from our surgery, and we can ablate, destroy the ovarian, the endometrial epithelium and stroma without excising the ovarian cortex. However, as Nicholas has just told you, we have to choose a good energy to obtain a good ablation of the endometrial epithelium, but without thermal diffusion toward the ovarian parenchyma. And there are, today, we have three methods to destroy, to ablate. The first is the carbon dioxide laser, and Michel has a very, very good and long experience. The alcohol injection, and Chandy presented his experience, and recently the ablation using plasma energy. Well, I discovered the plasma energy in January 2009, and there was a moment where I was looking for an alternative technique. But as my hospital does not has not the laser, I found this energy plasma, and I understood that it looks like a laser. However, it is easier to handle than the laser. And a few months later, when I was at ease with the plasma energy, I performed the first study, a pilot study, where women with endometrioma underwent plasma ablation and then a cystectomy in order to provide a specimen for histological analysis. And the histological analysis showed that the depth of the necrosis was almost inferior to the thickness of the fibrosis. Namely, the harmfulness of the energy was into the fibrosis and not into the ovarian parenchyma, underlying ovarian parenchyma. So at this moment, I said, okay, the plasma ablation could be an ovarian sparing tactic. Then, a few months later, we performed a retrospective comparative study. We compared women free of surgical and IVF antecedents with unilateral endometrioma, which diameter exceeded 3 centimeters. And I made up two groups. The cystectomy group, 15 women managed for January 2008 to December 2009, in a period where I strongly believed that the cystectomy, as presented by Nicola, is the best way to treat endometriosis. So I strongly believe that this time. And the second group, the ablation group, 15 women managed from January to November 2010, when I was at ease and strongly believed also that plasma is better. And we performed a three-dimensional ultrasound assessment and of ovarian volume and intrafollicular count at no earlier than 3 months. And we observed, even with only 15 women in each arm, we observed a statistically significant difference. Namely, women with plasma energy experienced a lower decrease of ovarian volume, a lower decrease of intrafollicular count in the ovarian operated when compared to ovarian use control, contralateral ovarian use control. And even after multiple regression model with adjustment of over confounding factor, the sole factor predicted for the decrease of ovarian reserve was cystectomy. Using this data, we started then prospective comparison, plasma versus cystectomy. And in order to avoid a very harmful confounding factor, which is the experience of the surgeon, we did not perform a randomized control trial, because in a randomized control trial, the same surgeon has to do two techniques, but very well, both of them, because when you perform very well technique and bad, less the other one, the result of the randomization is jeopardized. So we compare women managed by plasma energy in Rouen versus women managed by cystectomy in Clermont-Ferrand by Nicolas, Jean-Louis and Camille, for a very good experience in this way. And we have to include 25 patients in each group with unilateral endometriomas, no previous ovarian surgery. And the outcomes are the same, the reduction of ovarian volume, antimullary normal level, and the intrafollicular count at 3 months. To date, there are 22 patients in the plasma ablation arm, so expect to finish the plasma ablation arm before the end of this year. And now, we recently took the time to have a look backward and to see what's happened with all women who underwent the plasma energy in ovarian endometrioma during 2 years and a half, but with respecting a follow-up of minimum 1 year. So we stopped the inclusion of patients in April 2011. We excluded women who were included in the first pilot study where ablation was followed by the cystectomy. And we have 55 women managed by plasma, exclusively by plasma. Among them, 40% have not yet intended to be pregnant, so they are under pill, and 60% have stopped their pill in order to seek to be pregnant. Baseline characteristics show that 52% have already been operated for endometriosis, so not free of surgical antecedents. Only 20% were not nulliparous, and 42% have been known as being infertile. 45% of them had bilateral endometrioma, which is the risk factor for both recurrences and ovarian failure, postoperative ovarian failure. 75% had a deep endometriosis, and 40% have a colorectal endometriosis. Thus, 80% of them, 18%, had a sigmoid colon surgery and 29% a rectal surgery. Means there are patients with severe endometriosis in more than half of cases. And the spread of minimal implants was such that in half of them I could not destroy or or excise all the minimal implants, peritoneal minimal implants. And the Douglas approach was completely obliterated in 1 woman out of 4. Now, the recurrences rate with a follow-up, mean follow-up of about 21 months, but not shorter than 1 year, showed that we had 6 recurrences, namely a cyst, whatever the diameter was. So a cyst of 5 millimeters is a recurrence. So 6 women, meaning 11%. And I present the results with 2 Kaplan-Meier curves. The first one, the upper one, is as usual in the literature that it originates at the day of the surgery. However, in my opinion, is not the most appropriate. The most appropriate is a Kaplan-Meier curve taking into account only the period of risk to recurrence, to recur, namely the period without pill. Because as you know, when a woman has a pill, the risk of recurrence is very, very low. So you can see that in women without pill, the risk of recurrence is at 2 years was about 20%, which is very, very comparable with the cystectomy, the recurrence following cystectomy in the arm without pill of the randomized control study versus pill. Now the pregnancy rate, 67%, with a short follow-up, not very long follow-up, and I think that it's satisfactory because the rate of women with very severe endometriosis, 40% correct endometriosis, 40% known as being infertile, and we have 67% pregnancies and 60% of them spontaneously. And you can see that the period, the length of the period, meaning of the period from the surgery to the pregnancy is about 7 months. And as previously, we have 2 Kaplan-Meier curves, the first one from the date of the surgery, and the second one, more appropriate in my opinion, from the day where the pill was stopped. And the likelihood to not be pregnant yet is 46% at 1 year, 27% at 2 years, and I think that it's a pretty good rate. Now, let's have a look at patients, 6 patients with recurrences, because one may inquire whether performing cystectomy would have avoided these recurrences. The 6 recurrences occurred in women with frozen pelvis in 3 cases, and when you have a frozen pelvis, you know that the cystectomy is very difficult too. And among the frozen pelvis, 2 rectal endometriosis, 1 rectal vaginal endometriosis. Over 2 patients presented bilateral cysts, and both of them were newly gested. So we performed a very economical ablation on both ovary in order not to take the risk of failure, ovarian failure, because those women have not been pregnant and intend to be. Well, I think that having this data, I think that the cystectomy would not be done better. Now, if we consider that plasma were able to preserve better the ovarian parenchyma than the cystectomy could do, I think that it's a technique very interesting in women presenting other risk factor of ovarian failure following the surgery. Namely, in women with antecedents of ovarian surgery, women with bilateral endometriosis, elderly women, and women with a high risk of postoperative recurrences. However, if you want to compare accurate comparison between cystectomy and plasma, I think we need a long follow-up. Because as a woman recur, we have to have an idea about the results of repeated procedure. And I strongly believe that performing 4 ablations with plasma is better for the ovarian reserve than performing 2 cystectomy. And for this, we need a long-term follow-up. And I think that if all the arguments, in my daily practice, the plasma ablation is the first line procedure in young patient with prostate. I stopped the cystectomy 3 years ago. 3 years and a half. If you want to replace the cystectomy by plasma ablation, we need evidence. However, to date, I can say that plasma ablation is easy to do. It's a very reproducible technique. And it may be interesting for surgeons who try to reduce the ovarian tissue loss and try to reduce the harmfulness of repeated procedure when women recur. I think that the recurrences rate is not a goal, because I suppose that the recurrences rate with plasma is not different when compared to the recurrence rate for a cystectomy. You have to know that when you have a very large cyst, complete ablation is challenging. Okay, and a large cyst I used to operate in 3 steps. The 3 steps described by Judge and Michel. But I think that the recurrence rate is not a goal. And I don't propose plasma in women without partial pregnancy intention. But I don't propose cystectomy anymore, because I think that in that woman, the best procedure to avoid recurrences is either complete or partial colorectal. Thank you very much. And as I'm an ambassador of the World Endometriosis Society, as Francesco, I'd like to invite you in Sao Paulo 1 month before the World Cup. It's not at the same time. 1 month before.
So we need to take a long holiday then?
Yes. Thank you very much.